awarded with this. Also, we are having short surprises like short videos and mental health activities. This is the first time in medical conference we are conducting an emoji contest also as suggested by one of our delegates. So now we are starting with our academic quiz. Topic is essentials of nuclear medicine in routine practice. To elaborate on this topic, I would like to invite our guest, renowned nuclear specialist, Dr. Samir Sonasar. Sir is nuclear medicine specialist since 30 years. He is a fellow of Harvard Medical School, USA. He is a co-director of nuclear medicine and PET-CT at Medicon Clinic Hospitals, Pune. His special interests are nuclear medicine therapies. Over to you, sir.
Good morning. Very second your answer. Good morning. Thank you, Mukta Foundation, for giving us opportunity for contributions. Audience मध्ये कोण कोण आहे? Students असतात का? Students नाही. All practitioners. Maximum practitioners. दोन student आहेत. चला, मी त्यांना विचारलं. हे तुम्हाला आवडते त्यांना विचारायचं. हे मॅडमने ठरवलं quiz नंतर आहे आणि माझं quiz आहे. कौन प्रैक्टिस का है बराबर ऑडियंस की पहचान लैंग्वेज का है प्रैक्टिस का है जनरल प्रैक्टिस और जनरल प्रैक्टिस वेरी गुड वर्चेक दिला हे दिसलं पॉवर पॉइंट आर्टिफिशियल इंटेलिजन्स इन न्यूक्लियर मेडिसिन. अरे बाबा नाही कसं आर्टिफिशियल इंटेलिजन्स आहे तो चालत नाही. Nuclear medicine and routine practice. First of all, nuclear medicine. You know something? The name says it all. 25-30 years back, when I started practicing nuclear medicine, they used to put it in a different way. They used to put the spelling U first and N later. So it was unclear medicine.
Oh,
okay. So nobody knew what we do. Whether we make nuclear noise, what we do. Nobody knew. Nuclear, the problem was in those days, nuclear medicine was so kind of a rare thing that I remember in the country of India at that point of time, they used to give only 6 seats. So that's a don't sponsor of assets. Anyway. So coming back to what we do. On the left hand side, you are seeing the Ruby Hall Men's super specialty building, where my department is located on 3rd and 4th floor. On the right hand side, you are seeing Vanoli Ruby Hall. The white building there is the next building, newly built building. So ground and first floor is my department. Next slide. This is Ruby Hall's brand new super specialty hospital coming at Amanora. So it is another 250 bed hospital with all super specialty available. Next slide. ताई के मला देते का? ताई तो लॅपटॉप मला देते का? तुम्ही संधी पुढे करायचं. Okay. So this is my complete department. We have the first and bottom row, if you see, that's a PET CT scans. Middle row, top and above, you can see the SPECT CT machines. On the right upper corner is something which is very brand new technology. It's called peptide labeling and imaging system, which is used in the PET CT scans. On the right lower corner, what you are seeing is what is called the isolation room. Some of the patients we treat with a lot of radioactive material, and those are to be kept away from the normal people. That's why they are kept in this isolation room. The isolation room looks beautiful from here, but it has got around 30 inches thick RCC walls from outside. So when the patient is inside, the radiation cannot come out of the room. Okay, next slide. So briefly, we will be seeing what is basics of nuclear medicine and okay. So anyway, next slide. Okay, now here we stop. What is nuclear medicine? It sounds quite difficult, but it is a very simple thing. That yellow star which you are seeing is what is called as a radioactive isotope. In most of the 90% of the cases, it is technetium-99m. And then there is a chemical. So this joining of the radioactive isotope and the chemical is done outside the body. The marriage is done, and then it is sent in the human body by an intravenous injection. Okay. Now, what happens after that is we image what is called the function and metabolism inside the bodies. Next slide, please. Now, if you see, I have shown anatomical organs. What we inject will show, you see in the left corner, it's a brain, the function inside the brain. The left hand side, a thyroid, which is seen. Now, there are kidneys, there are bones, there are liver, and the lungs, and that donut you are seeing is a heart's cut section. Blood supply of the heart in the cut section. So this couple of things are very useful in your day-to-day practice. So my topic today is to tell you about nuclear medicine, how you can use that in your practice. Okay. असं काही जरुरी नाही की खूप अवघड आहे तर आपण काय लिहायचं नाही आपण काय पेशंटला सांगायचं नाही करायला असं काही नाहीये सो आय ट्राय टू सी हाऊ बेस्ट आय कॅन टेल यू नेक्स्ट स्लाइड routine application. Thyroid scan. Thyroid scan, what we inject into the body will go to thyroid based on the function of thyroid. Like I said, this is the function imaging. So typical thyroid, normal thyroid scan will look like this. You can see a thyroid gland and you will see salivary glands also. Because that tracer has that, you can say, capability of going to salivary glands also. So this is how typically we see a thyroid scan. Now, where or it can be used, but or other ways, how the thyroid scan looks in different patients. The next slide. Okay, now the first one is the normal. As compared to this, you see the leftmost. Okay, you can see simple black butterfly. So what I have injected into the patient has gone diffusely distributed in the gland, and you are not seeing anything apart from the gland. Now, if you see the middle image, you will see there is somebody has taken a bite of a thyroid gland, like there is an actual bite. Somebody has taken thyroid bite. Okay, so you are we call that as a cold area in the thyroid. And then on the right hand side, you will see that it's a like diffuse, enlarged, patchy uptake. So these are the typical pictures. The multinodal goiter, and there is a cold node in the thyroid gland, and diffuse increased gland with increase uptake. What that means we'll see little later. This is very important. This remember this. This you need in routine thyroid practice. You need. Next slide. Okay. For evaluation of thyrotoxicosis, you need this scan. Okay, patient comes to you with weight loss, typical tremors, palpitations, elevated T4, and remember most important, low TSH. Thyrotoxicosis is low TSH. Don't make that mistake. If low TSH means hypothyroid. Believe me, in my 30 years practice, I have come across hundreds of prescriptions from MD doctors, low TSH, known case of hypothyroidism. एकदम सिंपल लॉजिक आहे हो. TSH कमी झालं म्हणजे हायपो, वाढलं म्हणजे हायपर है ना, म्हणून ते लिहिलंय low TSH. A patient who has hyperfunctioning gland will have low TSH. Okay, एकदम लक्षात ठेवायचं. हे कमी झालं gland फंक्शन वाढतं. Anyway, next slide. This time. Next slide. Next. Okay, great. Patient with weight loss, palpitations, tremors, intolerance to heat, raised utility force, and low TSH. Come on. Just one minute. Okay, so you are saying hello. So you are seeing on the left hand side, like I showed in the first picture, increased pressure uptake in the thyroid gland. This is hyperthyroidism. But I am telling you what is mentioned above, weight loss, palpitation, tremors. The patient doesn't have hyperthyroidism. Now tell me, student लोग चला पहले बाद में छोटे. Clinical picture says, I am saying no hyperthyroidism. बोला. बोल that देखो कुछ very good. So we have increased size of the gland and increased uptake. It will look like hyperthyroidism, but we have another condition, subacute thyroiditis, where the clinical picture remains same. Weight loss, palpitations, tremors, and low TSH. Picture can be look like this. There is no thyroid gland seen. See, there is no uptake here. So whatever we have injected has not gone into the thyroid gland like this, and this is subacute thyroiditis. Now, why this thing has happened is very simple thing. You will find T3, T4 high and TSH low. Still, a scan picture is like this, and I am saying it is subacute thyroiditis. Why this happens is because when there is a viral or bacterial attack or any viral or bacterial attack on the thyroid gland, it breaks all the small pouches in which the T4 hormone is stored, and it will go into the blood. Because of that, if you take serum T4, 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 it will be high. TSH will be low because brain is sensing that in the blood there is lot of T4 hormone. So reduce that. So brain is sending message, reduce that. It is the message is for the gland. It is not understanding the gland got attacked by bacteria and there is inflammation of the gland and everything inside is released into the blood. That is why this T4 is high. Okay. This and this has two different treatments altogether. This one will need radioactive iodine treatment, which we will discuss later. And this patient You will not need anything. Nothing. I'm telling you, you comedy from for 3 days, the patient will get. Okay, such a big difference. Or somebody will say, I'll have to give you alcohol in this, if the pregnant lady, all other things will come in this. This doesn't need anything. All symptoms will go away when it's a self-limiting condition. It's an inflammation, so it can come back. If you really think it is very bad for this patient, you can give a short course of steroid. But otherwise, seborrheic thyroiditis is something very easy to manage. But remember, there is no biochemical or clinical way to assess whether it is hyperthyroidism or thyroid. This typically comes after any sore throat. Typical. You ask the patient, "Kasa dukla hota tha?" "हाँ, मागच्या आठवड्यात दुखला होता." "या आठवड्यात thyroid दुखला होता." Okay. Let's see. So coming to this, how to treat the hyperthyroidism? Radioactive iodine is a treatment of hyperthyroidism. I am making very simple statements here. Radioactive iodine is a treatment choice for hyperthyroidism. Radioactive iodine will permanently destroy thyroid cells. Don't ask what are the side effects. It is supposed to destroy thyroid cells. More than 50 years have shown that it is safe and effective. A definite treatment. It can be safely used in children at the age of 10 years. I know people who knew about radioactive will still today say, "Oh, it's young patient is sir, कसं द्यायचं?" काही नाही. Young म्हणजे 10 वर्षाच्या बच्चूला पण देतो आम्ही. रुटीनली देतो. असं नाही की कधीतरी देतो. Radioactive iodine, pure rates of radioactive iodine as high as 95%. Now, this is a learning point for you people. Your patients hyperthyroidism, you can diagnose. You can get easily for PSA. You can ask for thyroid scan. And if the patient is hyperthyroid, you can easily say give radioactive iodine. So you don't need anybody to tell you that whether to give or not, because you already have done workup. Thyroiditis का patient ला radioactive iodine देना criminal है. Thyroiditis का patient ला neomercazole tablet देना criminal है. का कारण it's a self-limiting condition. काही नाही केलं तरी प्लॅन रिकवर होणार आहे. रिकवर होणाऱ्या प्लॅनला तर तुम्ही neomercazole दिलं आणि सप्रेस केलं तर that's criminal. So don't do anything for thyroiditis. And for hyperthyroidism, go for this. This everything what I have written is international guideline. Coming to, you know that probably in the books it's somewhere written there's a bone scan, radioisotope bone scan. Not very routinely required in your practice, but I'm showing you for a simple reason. These are the variety in which the bone scan can be shown. Like osteomyelitis, I can find out the active infection of a bone. Sometimes I can find osteoarthrioma, fragile disease. What is that you can use it for? Use it for back pain evaluation. This patient presented with a severe backache, and at the end of the scan, I found that there is a right-sided sacroiliitis. We'll see. We have this technology. We don't do only bone scan. We do what is called as a SPECT CT. So bone scan is combined with a CT scan, and then you can get more accurate information. So here, the SI joint is showing inflammatory pathology. So backache is because of this hip pain evaluation. You will see that the suspicion of AVN versus arthritic pain is very easy to find out in a bone scan. So you can all non-inflammatory investigations are simple, non-invasive, no therapy, no pain required.
गणेश
नॉर्मल डिपार्टमेंट मध्ये बाहेर निघून गेलेलं असतं त्याचा 6 तासाचा हाफ लाईफ आहे. So don't worry about getting things done. For example, this is a useful investigation which you can ask your patient. Okay, this is
Out take out.
finding patients GFR of kidneys. Okay, this is a very quantitative information which will come from a simple test like Vinogram. You will see that what we do is we inject the radiotracer in the patient and the patient is lying under the gamma camera for half an hour. So what every 1 minute the camera will take pictures and what happened inside it will plot the graph. The tracer went to the kidneys, peak, then washed out from the kidney. This is how typically normal kidney works. So right kidney, left kidney, both curves are going down. So normal. Okay. In this kidney, you will see the right is normal, the left curve is going up. So it is obstructed kidney. So sonography showing hydronephrosis, dilated TCS, whether obstructed or not, the simple investigation can tell you. Okay. Now, this is what I wanted to show. That this is how a left kidney curve showing going up means obstructed. So a bachu coming to you, antenatal sonography done showing dilated peridilation system may not be a dilated or obstructed. It can be only dilated but non-obstructed. A normal left kidney would look like this, and dilated peridilation system, it is not obstructed because this line that is where we give a last 6 injection. There is a fourth dilation. Complete excision of pressure. So this is dilated on ultrasound, but not obstructed on renogram. This is a single most important investigation I want to tell you today. The most important may not be for your patients, but for yourself and your near and dear ones. This is called a stress area scan. Heart's perfusion or heart's blood supply to be visualized. Not only visualized, see it when the peak heart rate is there. If you walk or climb 6 stairs, your heart rate is not 78 beats per minute. Obviously, it will go to 120, 140 beats per minute. At that point of time, blood supplies are high. Normal माणसामध्ये coronary direct होती 3 to 4 times, and they will meet that demand. But if one of the coronaries is blocked, it will not dilate because of simple physics that it's a very strong or thick walled vessel. It cannot dilate because of the cholesterol deposition. Now, a test is done like this. Patient walks on a treadmill. At peak exercise, we inject whatever we inject. It goes to the heart, left ventricular muscle, and it gets distributed. In this case, whenever the peak heart rate is achieved, the top line is increased heart rate, but the blood supply. On the lower line, the rate has come down to normal, 78 beats per minute. And then again we have injected and we are comparing these two. Remember, like I told you for radioactive iodine, this is the international guideline of position statement made by American Cardiology Association. Normal myocardial perfusion study, that is a stress area scan, indicates less than 1% chance of having major cardiac events in next to 12 to 18 months. So 1.5 वर्षापर्यंत त्याला कुठलाही मेजर कार्डियक इव्हेंट होणार नाही, provided त्याची stress area scan normal असेल. Now this is position statement American Society. Now what the position statement means? That anybody, any general practitioner asking for this study, and if it is normal, you will say because there is a less chance of getting any cardiac event, angiography करू नका. असं जर सांगितलं, in court of law, the society will be standing behind you saying that this decision is correct. A patient who has a normal stress area scan does not need angiography, immaterial what is his family history, cholesterol काय, stress rate normal होती का, positive होती. Angiography मध्ये काय होतं फाइंडिंग? कारण मी एका पेशंटचा रिपोर्ट केला, कोणाला असं दाखवलं 85% LAD ब्लॉक, 70% RCA block, stress healing scan is normal. I know what that cardiologist is going to do with that. Don't get surprised. The patient will be asked to come after at least 8 to 9 months. So if you ask for this for yourself, for somebody who you know that there is high risk probability, and it is totally none. We do not use contrast. In routine nuclear medicine practice, we do not use contrast. I don't need creatinine for any conventional nuclear medicine scan. Look at this. Like I said, peak exercise ला या भागामध्ये तुम्हाला असं डोनट कंप्लीट नाही दिसत ना, इकडे थोडंसं लेस परफ्युजन आहे, याच्यात बघा इथे लेस परफ्युजन. आता पीक हार्ट रेटला असं होतं, रेस्टिंग हार्ट रेटला हे डोनट कंप्लीट झालं. So which means this did not receive proper blood supply at peak exercise, and when the heart rate came back to normal, the blood supply went. We call that as a reversible ischemia. This patient requires angiography, then angioplasty, or I'm saying revascularization by any method. Beta-plasty, balloon, J-type, bypass, काय पण करा. ते काय लेझर थेरपी लागू. पण रिव्हॅस्क्युलायझेशन या पेशंटला बेनिफिट होणार आहे, कारण रेस्टिंग हार्ट मध्ये तुम्हाला कुठेही डेड मायोकार्डियम दिसत नाही. इंड्युसिबल इस्केमिया आहे. हार्ट रेट वाढल्यानंतर इकडे ब्लड सप्लाय कमी पडला. So circumflex has a problem. So this patient may be having circumflex. Look at this. Circumflex 60%. Can you believe that? At 60% this is normal. I told you 85% there was no problem. This LED 70%, there is no problem in this anterior septal wall. This everything is happening in the lateral wall. So in this, what a cardiologist would have done, LED का open करो, leader block है, पर problem होता है circumflex में. Circumflex क्या है, minor artery इतना क्या करायचं नसतं. No, तुला करायला लागणार आहे. या patient मध्ये benefit किती आहे? This is how, this is artificial intelligence in nuclear medicine. Since 30 years we are using this. A computer is telling me that there is a मोठा problem है आणि रेस्पिरेटरी नॉर्मल झाले. थोड़ा टाइम पास नको पाहिजे. डॉक्टर किती बघणार तुम्ही? How nuclear medicine is different than CT MRI. This is MRI of two people. One person is alive, the other person is dead. We did a PET scan on this patient. You can see uptake here, which means this patient is alive. No, sorry, this PET scan. This is where there is no uptake. So PET scan, alive patient, you will see uptake. Dead patient, you will not see uptake because brain is not functioning. On the MRI, you will see it, but on PET scan, you will not see it. Moral very simple. MRI scan tells that you have brain. PET scan says you can have it, you can use it. Okay, short episode. हे इम्पॉर्टंट आहे. परत सांगतो, पेशंटसाठी नसेल, तुमच्या लोकांसाठीच आहे. प्रोस्टेट कॅन्सर, you must be seeing, everybody must be having somebody with prostate cancer. Okay, नंतर castration केलं, hormone therapy केली, त्याच्यानंतर this is after doing everything. The max, you can see, you can't even count 150. We give what is called as a nutrition PRIT for this patient. In one cycle, this is the situation. One intravenous infusion for 15 minutes. 1 month later, the scan is repeated. You will see this, everything is gone. That's the future of medicine. That's where we are going. Like I said, I can give you something very useful you can use in routine practice. This is something where we are reaching. No doubt. In certain cases, I have to come down and tell you this is where you can use a thyroid scan. But we are heading here. Treating cancers with that ease. Okay? मला वाटतं सांगू. Okay, most important thing is don't stop and asking questions. Want to ask them again? No, मी तुम्हाला प्रश्न विचारलेला आहे, तुम्हाला उत्तर द्यायचे आहेत त्याची. तुम्ही विचार करता. Yes.
डायरेक्ट
पेशंट रेडिओला पाठवू शकतात, प्रोव्हाइडेड देर आर नॉट टू टेल पेशंट इज प्रेझेंट.
पण मग बाकी मेडिकल थेरपी काय द्यायची?
कसं आहे डेटा ब्लॉक द्यायचे कॉम्पिटिशन साठी, कारण रेडिओ आयडीन एका रात्रीतनं काम करत नाही. रेडिओ आयडीन दिल्यानंतर पेशंट 6 महिन्यांनी हायपोथायरॉइड होणार आहे आणि हायपोथायरॉइड मॅनेज करणं खूप सोपं आहे. 12.5 माइक्रोग्राम to 200 माइक्रोग्राम टैबलेट अवेलेबल है, 25 अवेलेबल है, 37 अवेलेबल है, 100 अवेलेबल है, 112 अवेलेबल. तो patient has to take only one tablet to become normal. So give it, use it. Like I said, universally accepted treatment of hyperthyroidism is reactive. Simple.
The most interesting fact, I'm Dr. Brodaway, orthopedic surgeon, was one of the AVN versus inflammation. So in this post-COVID era, what we are facing a problem. Recently, we have found the all India group of AVN and all that. So what we are facing is, it's like an epidemic of avascular necrosis. And I try to dissuade the patient for THR. I don't persuade them. I say that you take these medicines because they are all young patients within 30 or 40 years of age.
Right.
But still, when I opened 2 of them, what I found was the collapse of the head was not that much as compared to the inflammation of the synovium. So, will the nuclear medicine help me?
The picture which I showed here was not existing.
So, can we differentiate in COVID?
Yes, not COVID case, right? Any histopathological, see, no imaging can give you histopathological diagnosis, but the pattern that we see, the pattern we can always say is a periarticular joint or the acetabular involvement. Many times it happens. If joint involved evaluation means we want to see whether there is a head of femur versus the joint space versus the acetabular. That we can do because of the SPECT CT. Earlier it was very difficult to look at only nuclear scan and tell. Now because we have a fusion imaging, we are very precise about it. Stress cardiac साधारणपणे सेफ साइडला 1% जरी 12 to 18 months म्हटलं असेल तरी 1% नंतर रिपीट करणे is very good. I am telling you, heart rate achieved more than 85% of the target heart rate. Patient having symptom, not having symptom doesn't matter. What kind of a every patient who undergoes the stress cardiac will undergo a routine treatment test. So त्याच्यामध्ये रिपोर्ट मध्ये लिहिलेलं असतं आमच्याच कार्डिओलॉजीच्या रिपोर्ट मध्ये लिहिलं असतं स्ट्रेस टेस्ट पॉझिटिव्ह, तरी पण स्ट्रेस cardiac निगेटिव्ह येतो. Negative assume most, I think 30% of my patients who go to their routine investigation for insurance company and their stress test is positive. Now what to do? Insurance company said we can't pass your claim. Then these people send patient to stress cardiac. It turns out to be negative, and that report is more valid than the routine test. येऊ शकते म्हणून तुम्हाला दाखवलं की एंजिओग्राफी आणि स्ट्रेस कार्डियक एकमेकाला रिप्लेस करत नाही, एकमेकाला कॉम्प्लिमेंटरी आहे. म्हणजे बऱ्याच वेळा असं दिसेल तुम्हाला की लिजन मोठा आहे पण पोल ऍट्रस डेव्हलप झाल्यामुळे त्याच्यामध्ये ऑलरेडी नॉर्मल परफ्युजन चालू आहे. So unless and until I am saying that RCA directly showing perfusion pool ऍट्रस डेव्हलप फ्रॉम LAD असं जर असेल आणि इरेग्युलर लिजन असेल तर यू बेटर ऍड्रेस दॅट लिजन अँड रिलीव्ह इट. कारण LAD परफ्युजन ऍट्रस RCA ला सप्लाय करताय, तो LAD गेला तर ते LAD ची थेरपी पण जाईल अँटी सेप्टल आणि इन्फिरियर पण जाईल. In that case, ऍड्रेस. Okay, thank you.
Many times we get patients and we get patients who have been CT and medical gam. So that time we do self cardiac. Because CT corridor is showing a lot of calcium score more than 400, 500, 600, but patient has no symptoms. So in that case also stress challenge is important. Stress challenge is negative, there is no need of angiography, we can just follow the difference.
Good. Whatever I said got validated immediately. Thank you very much. Yes.
Will you guide us to differentiate between hyperthyroid and hyperthyroiditis? Without
Yes.
disease, without disease.
Without thyroid scan, it cannot be done. That's the teaching point. Only differentiated is the thyroid scan. Thank you.
Thank you, sir, for such an interactive Sir, I would like request you to please pick up any number from 1 to 15. We are going to announce the lucky winner. Any number.
7.
Jagannath K. Welcome. Congratulations, Dr. Jagannath K. So he's practicing at Bella. He's from Bella. Now we are sending a short link quiz on your WhatsApp group. Please open your WhatsApp and the Medicon MCF invite group. You will get a link. You have to answer the questions within 3 minutes. The time starts now.
Slowly.
Okay, we'll wait.
Oh, join.
After 2 minutes, your the link will be invalid. You won't be able to submit the answer. So be quick.
अगर इनको नहीं मिलता है उसके ऊपर लगाती है उसको नहीं मिलता है
ओपनच होत नाही
मांग रहा हूँ कितने टाइम से शटवा मिल ही नहीं रहा तो क्या सोचूं मतलब ऐसा से पता नहीं कहाँ गई कोई तो ऐसे छुपा के रखते ना पापा फिर हम लोग को मिलेगा इन सब का तुरंत मिल जाता है भाई ये सब क्या पहनते हैं
ये तो खराब है
ग्रे और वो नीला वाला पहले फेंके और लाल वाला
अरे नीलम तरीका
The winner of the quiz will be declared after a short video. सिलेक्ट होत नाही मॅडम आता सिलेक्ट होत नाही
Everyone, the password and the user for Wi-Fi is being distributed right now. Please use it so that you can access the Google form page and also for the future quizzes.
फॉर फ्यूचर लिंक मतलब नेक्स्ट लेक्चर के लिंक के लिए आप लोग जो वाईफाई यहाँ का है उसका पासवर्ड दिया हुआ है दैट यू कैन यूज फॉर दिस पर्टिकुलर लिंक फाइल अप जिनका सबमिट हुआ है उसमें सिलेक्ट होंगे
कागद स्क्रीनला दाखवू शकतो तुम्ही तिथनं हे करा मी हे कुठे लावलाय समोर लावलाय तो आहे का तो समोर आहे का सर तो समोर लावलाय पण ते स्क्रीनवर
small video about how to remove a foreign body from eye for OPD practice. And one thing I would like to mention, every doctor, whenever doing these procedures, we are expecting that the rest of us about all this kind of medical practice, the doctor is taking care. Here, in this small video, we are just showing the procedure. So here, the doctor has explained the procedure to the patient. After taking all aseptic precautions, the patient has been positioned. Headlamp ascent, things are much more easier for the doctor. The patient has been instructed that he is not supposed to move his head side to side, etc. So if it is just a foreign body on the superficial layer with a cotton bud which is wet by the saline water.
Space houses for the body. You will go on. Stay with you in consent or sharing with this makes it conditions help relying the correct way before they are. Must keep checking if this is the case. Using your hands in head forward and line the patient flat stays up. Mind the patient to keep the head pressed backwards against the bed, not to come forward or roll side to side. Now examine the attitude of the body first bring forward. If there are any standing signs that you know, I hope it initiate and as provides prepare for the next session. Instead of painfully diagnosing the scenes in use. If it looks like then place an action. Also examine one of the factors by inverting placement. If a foreign body comes, no other seen signs of presence, and pause to explain again to the patient what you're going to do, reminding them that this is always initially approach to naked eye, not looking down the eyes, so that pause to approach. What's close? Slowly upwards or rolling, moves foreign body away. The foreign body remains external tension or the needle. You know, your patient's operation to make the procedure safe, better for bodies to deep. Or there are signs of resistance and repair perspective. When using a needle or concentration diagnosed right behind the eye, keeping parallel to the surface of the cornea. Do not approach the needle towards the cornea. Get the needle in position, not looking down the eye, so that forms your head watch. Put down the eye and see the line of the slowly carefully dissolve. Roughly, also, one day must support a warrior, and it's still unfelt remove. Sometimes it's safe to leave it. If we return after 2 days, all the softens up, and it's easier to remove. If the needle can't be in the hospital and the slow on the ground. A moist cotton bud is used to remove the rest, leaving a small ridge.
Thank you, Divya. Now it's time to declare the winner of the quiz. Winner of the quiz is Dr. Pradnya. Her email is pradnya@gmail.com. Okay. Pradnya. Congratulations. Dr. Pradnya.
Namaskar, let me introduce everyone. Dr. Ramesh Ramke sir, ophthalmology, CMA practice आहे पण सरांचं काम त्याच्यापेक्षा खूप जास्त आहे. डिटेल इंट्रोडक्शन नंतर देऊया आता.
Two things I want to add. They are shown how to improve the average.
Sir, my
One thing that has been always a mistake is that you are not using sterile cotton. Make sure that you use the sterile cotton. If not possible, use the sterile. For next day and within 2 to 3 days we get the initial eye even with the head of permanent or family. For the addition that has been used here, never use a cotton bud which is not stuck. Secondly, if you don't have cotton bud, put the sterile and put a plain anti condiment which adds to the lubrication and gives comfortable. Thank you. Sir, topical validation topical dialogue is always usually topical dialogue you may not have if you do it. Okay, the best thing is you can use 2% dialogue in your training. You put the no, that's
So we are running out of time. We are only
question answer no because videos we have just putting them as tips of learning. Okay.
I request Dr. Hange sir to please participate.
So Dr. Pradnya Doshi.
Although in the clinical practice, we are very alert and continuously upgrading our medical knowledge to do best results for treating the patient. To guide us on medicine medication errors and ensuring patient safety, we have renowned Dr. Kapil Prasad with us. Invite sir on us. Since head of neurotrauma intensive care unit, he is affiliated to Grand Medical Foundation Ruby Hall Clinic Guru. He is president of ASA RCC and has presided various organizations. He has authored many books. His area of interest are neurocritical care, mechanical ventilation, sepsis, and organ donation. I request sir to start with the
Probably they are not taking 50, so I try to get in there or
Okay, like change that. Good morning. I'm nervous. Two things. To speak after the survey, very difficult. And second thing, what such a big audience and big audience. Orthopedics are there, cardiologists are there, ophthalmologists are there, GPs are there, and we are there, and nuclear medicine there. I'm not here to give you any teaching. No. I'm not going to tell you anything new. I'm going to share the cases I came across. I am the part of that case management. Every case is in a real life. Every case is the truth. What is happening over a period of the last 15 or 10 years? We talk a lot about the Consumer Act. We talk a lot about the doctor safety. We talk a lot about soft target as a doctor. I think it's reverse way. Why can't we discuss about the patient safety? Why can't we do everything which is related to patient safety? Why can't we manage the patient in our routine, what we used to do in the last 25 years, and see the patient safety? Any court of law doesn't see your errors. They see your intention to cheat. I have gone to the 3-4 criminal cases and I was accepted very easily. The judge said that the intention to cheat was right. And that gave me the confidence that why I should talk about medical legal. त्यांची भीती का घ्यायची प्रत्येक कॉन्फरन्सला मेडिकल लिगलचा लेक्चर नसेल तर आपल्याला ती अर्धवट कॉन्फरन्स असते वी आर एव्हरीबडी आय शो द केसेस यू फाइंड आउट दैट देयर आर सो मच डे टू डे लाइफ वी आर नॉट बॉदरिंग अबाउट अ वेरी सिंपल थिंग एंड वी आर इन ट्रबल so I am not going to talk about any doctor safety or anything. I am going to talk about the patient safety. Medication error is a human error. It is accepted. The problem is hiding the error is not accepted. Not documenting the error is not accepted. And not sharing is not accepted. If you what happens, like if I am putting the central line and it goes into the pleura, it is a no complication. No need to hide. If I am putting the IC and it is going somewhere else, it is a no complication. No need to hide. If I given a certain indication and I miss, you need to see that whether have you follow the basic protocol. That is what it is. Just very basic use. Use the idea to where we are missing the thing. So error is human. You did all data is from 1999 from USA. How much they are documenting? I am sure if you go on site and try to find out the medication error in Indian city, you will find zero. It's like UP. There is one of the best place to live because this crime rate is very less in UP because nobody documenting. No FLI documented there. Nobody dares to go to the police station. So are you going to buy the land in the UP? Less likely. In Bihar, sorry, I am not going to demoralize or commenting on any state, but I am trying to say that the documentation. One of the major drawbacks to the medical system, which never taught us during our curriculum, is that the documentation. And believe me, yes, for the documentation, everywhere, so whatever you are doing, please write down on paper. Whether you are in the OPD, whether you are in a nursing home, whether you are in a tertiary hospital, whether you are wherever you are coming across, please document. When I just search on the internet about the medication error in ICU, 1,57,000 articles I got on the medication error in ICU. What? In folder. In OPD basis, there will be 100 folders. That's the fact. So I am going to share the 5-6 cases and that gives you the idea. Now, this particular lady was a sister by occupation. She was a matron in a government hospital. She was admitted with the history of the pneumonia. We gave her antibiotics. She was severe. She was on high flow oxygen. She was tachypneic. She was in ICU. We started the piperacillin tazobactam.
And on 7 days, she recovered. Her pneumonia completely cured. Oxygen requirement come down to room air. So we said, okay, shift out. While filling up the shift out form, one of the junior most doctor, believe me, the most honest doctors in every field is the junior most doctor. Because they never learn the tricks in medical field, how to hide, how to not to document. So they are very honest. He written on a paper and he came to me that is, sir, this lady had an allergy to the piperacillin. So imagine the situation. We already given us 7 days of the piperacillin. On the 7th day, at the time of the discharge, that unit doctor saying that there is a list of the piperacillin reaction or adverse event. These are the routine problems. What to do? What to do in this situation? The common thing you have to fortunately, the lady didn't have the adverse reaction. So the history, don't miss the history. We have done a piperacillin, nothing happened, so the history was doubtful. I went back to the lady, to the matron, asked, give me the history, why you are saying you are allergic to the piperacillin? You are not. She said, while giving an injection to the patient, I used to have a reaction. So, see, the history said that she never had a piperacillin reaction. In a government hospital, while giving a piperacillin to some patient, she used to scratch her hand. And then she probably self-made reporting that she had the history of the piperacillin. See, these are all two cases. These are all related. History. Please, while prescribing the any antibiotic in OPD, just take few seconds to take the history. Just see whether you are allergic. If you are allergic, just ask what exactly happened. Looking at the medicine, if you are getting the rash, then that is not the allergic reaction. Believe me, I am not joking. This is what the reporting happened, and I am like to give those examples. What is in front of the thing? So the first thing, don't take medicine very lightly. Whether it is a amoxicillin capsule or whether it is the injection of penicillin or whether it is a NSAID. We prescribe NSAID like water. I will come to that. You will come to that. What will happen? Yesterday, I had a patient from the ward who was about to discharge post-operative spinal injury. At 11 o'clock, in the sister given a paracetamol injection and he had a cardiac arrest. And he's on ventilator in the almost very difficult to explain. But fortunately, that patient has received the 3 doses prior. That is very difficult to label it as the adverse reaction. But it happens. We need to document, but document. You have documented everything. So please take the history. Please take the proper history. Document it in a proper way and pass on to the your next study. Second case, this happened some years back. The patient was a COPD and shifted to the ward. Then from ward again he came back to the ICU with a BP of 60. So we said, okay, COPD, ward, ICU, more than 10 days. So typically, the first time we did a hospital acquired infection. We intubated, ventilated, fluids, antibiotics, all nonsense things we did in ICU. Believe me, I always say it is all nonsense things because it doesn't work in that situation when the patient is terminally. And patient succumb in next 1 week time, he succumbed, he expired. It was not allowing me to accept that death because he was recovered, he was shifted to the ward and planned to discharge. What suddenly happened to that patient is the patient dropped to the BPCC and he came back to the ICU. So I went back to the record, I checked that. And the history was, what I found, the patient was on prednisolone 20 milligram and sister gave prazosin 20. There is anything happening. So we are the things wrong. So everybody started shouting on the who they would shout on who? Sister. So one of the most soft targets in our practice is our juniors and the sister and the maushi and the ward vice. We never shout on the senior doctors. We never shout on the colleagues. We never ask them the proper history. And that's what happened. Where the thing is wrong? Doctor's handwriting was very bad. The first thing what I found, I do not say the name of the doctor. I was involved in that case. My handwriting is very bad. Now don't ask me your history. This is the reality. What you mean to say? Illegible handwriting, don't try to read them. Don't try to follow them. as far as possible, write a clear order on paper in a good handwriting. What I do in my practice, I always ask my junior colleague to write down my notes. I give them some helping hand and my handwriting is very bad. Please. My handwriting is very bad. Everybody is tired from the first standard till today. But it never improved. That is what I honestly. And now I'm very happy because my hospital brought the EMR, so I don't need to write down anything. This is how simple thing. Always write the exact spelling and the name. Always write down in the capital. Always write down in a clear handwriting. Don't try to read those unclarified or the vague words. Those jokes are now very common on the WhatsApp. How to read the only pharmacists can read the or the doctor. That is the bad practice. You don't forward that joke to anyone now. Henceforth. That is not showing us the good image of the doctors. We are more going towards the medical legal. Now tell me in both cases, who is responsible? Just our laziness, just our practice, just our overall culture. Our culture of the medical practice is responsible for this two cases. And I learn a lot. I'm learning every time. I'm sharing these cases with my team. I'm sharing these cases with my hospital. I'm sharing these cases with everything. And I am trying to educate everyone. What I did wrong, I was involved in these cases. Please don't do in practice, even if you are in OPD. Third case. Recently, you must have been heard our transplant team went to the nearby place and they brought the liver, they retrieved the liver and they were coming with the 120 speed. You know that transplant ambulances are like a chief minister ambulance. There's a green corridor. So they are running with the 120 speed and they make the accident. So our driver, two ward boys, then our liver surgeon, everybody was in that ambulance. Fortunately, everybody was alright. Liver surgeon was alright. Your ward boys were alright. They had this liver surgeon has a sternum fracture. We settled down him. And so we were just going to the one by one patient, and there was a ward boy who was absolutely alright. He came walking. He said, I have a lot of body ache. So it is typical body ache. So what you will use? We get the lineup injection, painkiller, immediate pain relief. Within few seconds went into the cardiac. Bradycardia, hypotension, and cardiac arrest. It was the hypersensitivity reaction to the diclofenac. So immediately we resuscitated, intubated, ventilated, given idea and this thing, and we immediately recovered him from that. In pain next 3 days in ICU. And he was all right. So look at what was our intention to give him the pain relief. What we did, sympathy. What we did, empathy. We explained to the family immediately, this is our ward boy, this is Ruby or ward boy. We will immediately settle down. And what we did, we pushed him to the ICU, he came walking. So now question arises in this situation, what to do in emergency? Diclofenac is a medication left and right we prescribe. Even at home also we give the tablet over or tablet combiflame. You need to be extra careful. Now in this case, if you go by this case, we did everything right. What we missed, patient was conscious. Patient came walking. One had to ask him the history of that. If the patient came unconscious, and if you give diclofenac and if you have a reaction, then your intention to treat was good. So it may be acceptable. Like in other case, I told you the patient had a cardiac arrest in a ward with the paracetamol injection. So my intention is not to create a fear amongst you. This is a very simple thing we are using in our practice. Intention to treat is always important. If the patient is conscious, ask him. Don't rush for the medication. And if it is must, then under the observation, you can start with the slow infusion. That is another alternative. These are the things regularly happening. Probably we are reporting or not reporting. That is the only difference. But these medications, NSAID, ampicillin, penicillin, we know that these drugs can cause the allergic adverse reaction. Why not to take precautions? Court case. Cardiologist is here. The old lady, 65 years, admitted for the elective angiography, coronary angiography. As a routine, they gave injections to Supacet, pre-procedure, this thing. Post injection Supacet, she had a cardiac arrest. This happens. Now the situation is, relatives are asking, why don't you rate, or why don't you check that she had hypersensitivity? So in history, it was mentioned that there is no hypersensitivity reaction to the any drug. But if you go and read the leaflet of the Supacet, it is written that you have to do the antibiotic test. How many times we read the leaflet? No one reads the leaflet. How many times we read the any antibiogram leaflet? Nobody reads. But we are in a hurry. And what was the indication of antibiotic? You are there, sir. Actually, I said, what is the indication of the antibiotic before the any routine coronary angiography? Referring Genta was the previously, nowadays is a Supacet. It is very difficult. But again, how to prevent that? If the patient is conscious, if it is walking in your OPD, walking in your nursing room, walking in your procedure, walking in your minor, please ask the history that do you have allergic reaction to any medication? Takes 10 seconds, 20 seconds, 15 seconds. Like Samir very confidently said, I don't use contrast. I agree, but still you take a history. Do you have allergy to the any medication? Because we don't know at what time we are going to advise the thing, and in probably that flow, they are going to miss that history. So in this case, preferably avoid the unnecessary medication. Second, if the patient is conscious, ask the history of the allergy. Third, further extra side, just slow infusion. Rather than pushing it, put it in 100 ml and give it over the 1 hour. It doesn't matter. If there is at all reaction, you may pick up early. You might land it with the mild reaction, and you will be safe and your career will be safe. It is very difficult. This lady is vegetative. Since last 6 months, this lady is vegetative. Okay, so it is very difficult for anyone to defend, but it is very difficult to avoid. It's just take an extra precaution. Next case, again cardiology. Patient was about to discharge, and then here cardiologists are very busy. They are in a cath lab, they don't have time, so they will advise on the phone, and even their assistants are very busy. They will also advise on the phone. Prescribed tablet cardiovas 3.125 and the ward doctor written is 31.25. And it is to the pharmacy. Fortunately, that was the Rubior pharmacy. So he called me back and said, 31, shall I do the 10 tablets 3 times a day? I said, wait. Probably there is something. But everyone, you will not get the clinical pharmacy. You will not get the independent pharmacy. You will not get the disorder. How to avoid that? Very simple. Whenever you are advancing on the phone, double check. No, please stand. So, I am finishing. So the very important step, double check. When you are advancing on the phone, double check. Cardiovas 1.3.15. 3.15. Use the social media. WhatsApp. Say, ask them to send the WhatsApp cutout to what they return. And you have to repeat the order when you are giving. Repeat the order. Cardiovas. So, see, these words are very high level for the junior, for the top reward. Not necessarily they are every time they educated. And they are so happy in writing and they are delighted. I am writing the cardiovas 3.15. So, see, their pleasure is something different, but we are at problem. Okay. So, this is very difficult. Clear, loud, double check, repeat the order, verbal orders, or check use the smart social media. Now, this is very interesting last case. This case was Jitendra Sharma. He was posted for the indirect laryngoscopy. There is an indirect laryngoscopy. They found there is a lesion. So the next day they posted it for the direct laryngoscopy. Jitendra Sharma went inside and everything was normal. Any guess?
Same name needs. Same name patient.
Same patient. So there were two Jitendra Sharma. Okay. So first day the Jitendra Sharma had a lesion. Next day that it was a very OPD and he was a very busy ENT specialist. So he is the assistant Jitendra Sharma. They did and they found it. So this is not the reason of overcrowding in this thing. Why we are doing repeatedly? I have came across so many incidences in a private. When we are in a party, they shared. They did the endoscopy on the endoscopy on the another knee, or they had something. You know, I did the nerve biopsy on the opposite side. When I was in a training, the lesion was on the right side posteriorly. So we did everything marking. We asked the patient to prone. The patient was prone, but we are doctors. We are very adamant that the accurate doctor. We never change the side. We never put the there is the mark gone. This happened. The most important thing, we realized on table that the side was wrong. Immediately we put the ICU, we corrected. We went to the air department. At that time in 1992, I am saying, and in the government hospital, we explained. He said, "Okay, have you with the patient all right? All right, go. Okay, next day do the biopsy. Next day we do the biopsy on the lesion." But documentation, information, develop the informed culture. That means everything that happens informed to your system, and that's what the major. Now, in the slide side, the medication. Please avoid such medications. Everybody enters in the MR medical. Please entertain them, but please guide them. You cannot have the look like medication. So this is some other antibiotics, these are other antibiotics. Dosing is different. Please don't use that. See, if the 10 milligram, 20, 30 have the all same color, just request that MR that I am writing your 1000 tablet, just make the color change at least. Don't change the MR, change the color. I don't come in between anybody's personal relation. But if you can guide them, if you are using so much, very simple. See, 10 milligram and 40 milligram has the same color, you are going to make a mistake. Yes, you can say that looking at the color, you might pick up that he probably the wrong is this. But one is Medazolone, one is Isomeprazole. What is this? It is very serious. Please don't keep in your medicine box. It is in OPD also. Look at one is the paralyzing agent, one is the sedation, and one is the practice. Look at the same bottle color. You are going to make the mistake. The simple thing is the color coding. Just change the color of the their caps will make your life more easy and safe. And the your patient is safe. Phototic, all of us know that these are phototic. It's such a beautiful lady, but if you take it from the so what I correlate with the medication. From every side, it should be a similar dose and the drug. Then you will be able to avoid those medication failure. So, medication error is the human. Nothing wrong in that. Nothing wrong in the medication error. Don't hide that. Don't blame it. It is very easy to blame your juniors and the soft target. Discuss it. Find out the root cause analysis. And your patient safety, because one medication error discussion is going to prevent any medication error in future, and that is what the patient safety. Why I should bother about the medication? I will never bother about the medication. I will bother about my patient safety, and that's what the whole purpose of this short lecture. So make sure you know of the any allergy or adverse reaction. Do not interpret your handwriting and double check those. That's what the carry-on message I would like to give. Thank you.
Thank you, sir, for such an informative lecture and very important lecture. So moving ahead, our package. I think because of sedentary lifestyle, many are suffering from this symptom. To throw light on this topic, we have a famous orthopedic surgeon, Dr. Rishikesh Surgery. From his slow introduction, he is a practicing orthopedic surgeon at the clinic and nursing home since 1998. He is faculty of AO Trauma College in Germany. He is visiting faculty at Bharati Vidyapith Homeopathic College. His areas of expertise are trauma, fracture management, and limb reconstruction. His special interests are in rheumatology and metabolic bone disorders. He is passion for Indian classical music and learning of
सरकारी नाही सरकारी मिळतच नाही जेवण
अरे भाऊ हे 2 टाइम घ्यायला सांगा हे 3 टाइम घ्यायला सांगा आणि हे 2 गोळ्या आता घेऊन परत एक केलं सांगा
ही 2 काय ह्या दोन्ही एक सकाळ संध्याकाळ आणि ती आता
या दोन
After two interesting lectures from senior consultants, it's switch
आता
over
गेलेल्या
to a
lecture-मध्ये घेतो.
different topic
सकाळचं
altogether.
हे नाही.
It is very common, probably. Yes. This is the commonest complaint, probably only next to common cold.
पण
So
जसं
everyone in this hall and everyone in this world will suffer by backache sometime or the other at some point of time in life. So, and the work loss or the economic strain due to backache is much more than we think of. Because work hours are lost and lot of expenditure is to be made to treat this condition. The estimated work loss or the economic strain is around 1 lakh per patient per year. That is the estimation, right? So you can imagine the just a brief introduction to the anatomy of this lumbar spine or the spine as such whole. There are 7 cervical vertebrae. There are 12 in the thoracic region and 5 in lumbar region. The skeletal parts are apart from the vertebral body, we have the pedicles which go posteriorly. Then the pedicles are joined together by the laminae, and there are transverse processes and spinal processes for the muscle attachment. Also, there are intervertebral joints, which are joints just like any other synovial joint in the body. So that intervertebral joint will have cartilage, synovial membrane, and capsule as well. And the whole structure is then supported by ligaments, muscles. Right? So here is a brief.
नाही लागायचं कमी होऊन जाईल.
In short, this is the posterior view, this is the lateral view, and the anterior view of the how this spine looks. So this structure is mainly responsible for our erect posture. Okay, so the vertebral bodies, individual vertebral bodies are responsible for weight transmission, and the intervertebral disc, which is like the pulp, held together by annulus fibrosus, and the pulp does the shock absorption, whereas the annulus holds the pulp together. So that is what the front portion of the spine does. If you see from the back, this is the spinous process. These are the transverse processes, and the intervertebral joints. I'll show it on you. Show it on the X-ray when it comes. The intervertebral joints. So once this function is understood, that it transmits weight, it also absorbs shocks, and because joints are provided, it will also provide movement. So imagine someone carrying 10 kg weight on his head and tilting sideways or tilting frontways. So the physics here is that if a person of say 60 kg has an upper body weight from the pelvis to his head is around 40 kg. So if he is bending forward, the vectorization of normal center of gravity lies center here, right? So the center of gravity will change as soon as the person bends forwards, and the back muscles are and back structures are put to strain. And that's why the forces going through this part will be in the multiples of the vectors. That is 2 times of the body weight or 3 times of the body weight. So you can imagine if you are sitting right now in your chair and your weight is 40 kg, right now your spine is balancing around 80 to 100 kg of weight. If you look at 80 kg, you will not be able to even think of lifting it, but the body has beautifully balanced this with musculature and its structure. So that's the function. आणि इतकं कमी होतं म्हणून की काय? The central part is a hollow one, the pedicles and the laminae, and in between the spinal cord is transmitted, and through these intervertebral foramens, the nerve structures are passing. So apart from weight transmission, apart from movement, apart from shock absorption, also neurotransmission is going on there, which is the most important function of spine. So the neurological part spinal cord will end at L1. So the upper motor neuron will end at L1. Then there will be nerve roots, and the thecal sacs and the nerve roots will be there below L1. So if you have a lesion in the lumbar spine, you are always looking at a lower motor neuron type of paralysis. And if you have a lesion above L1, it is an upper motor neuron type of paralysis below the level of that lesion. And at the level of lesion, it will be lower motor neuron type of paralysis. Now, in cases of lower backache, as far as the cause is concerned, a very important history taking and clinical examination is mandatory because that is going to lead to 80% of the diagnosis. You will need your investigations only to support your diagnosis, and proper history taking and proper examination will lead to 80% of it. So, to segregate the case of backache, someone enters in your OPD. The first questions which I ask usually is if it is only backache or backache associated with radicular pain. The second question. Also, backache, any hip pathology will also lead to similar complaint of backache, and the sacroiliac joint will also lead to backache. So you have to be careful while examining the patient. So history taking is important. The first question to be asked is if it is only backache or backache with radicular pain or leg pain. Usually the protocol which I follow in my clinic, and it is a very easy one, it takes hardly 2 to 3 minutes to examine the case of backache, is irrespective of age and sex. First, make the patient supine. You should examine usually the tendency is if it is backache, you start palpating the back. I would suggest that you make the patient supine and first try and feel the distal pulses. If the patient is complaining of backache with leg pain, first and the foremost thing, and the most common missed thing is the vascular cause. We tend to think that it is a neurological cause. I have myself missed many cases in my early days. So I have made it a habit to feel the distal pulse. Dorsal pedis is very easy to feel, and you can easily do it while you are questioning the patient. Then go for the muscle power in lower limbs, dorsiflexion, plantar flexion, knee extension, straight leg raising against resistance. So you can grade the power easily and determine the power loss or if there is any neurological compression. Then you go for the straight leg raising test. This is a very important test that will tell you about the involvement of nerve root. Because in the supine position, the nerve is relaxed. Straight leg raising test itself is self-explanatory. If you abduct the limb, the nerve is going to still get relaxed. And if you do it in abduction, it will be a false positive one, false negative one. So the patient may have a root stretch and still he will say there is no pain. If you adapt, the nerve root will stretch. So it should be done in a straight position, and it is a passive test. Remember that. Don't ask the patient to lift his leg on his own. It is not a active test. You have to lift it and try to stretch the nerve on your own. So that is a very important test that will tell you about root involvement. The figure of 4 test will tell you about sacroiliac joint involvement. If it is positive, if the patient has pain on figure of 4 test, it will be a sacroiliac involvement. Now the axis deviation test. In today's, I just mentioned that the post-COVID era, we are experiencing an epidemic of avascular necrosis. So you have to just flex the knee, flex the hip, and try to take it towards the opposite shoulder. So if you are examining the left side, you take the knee, flex the hip, flex the knee, and take it to the right shoulder. And if patient has pain on that, that means the axis deviation is positive, and probably you are looking at avascular necrosis rather than a back condition. And also you have to check the rotation of the hip. So you have to rule out the hip hip pathology. So this is all you have to do in supine position. Then you make the patient prone and then try to feel for local tenderness, spasm, or the step sign. Step sign will be positive in spondylolisthesis. That means the vertebrae are not in alignment with each other. One vertebra is moving forwards over the other one. Or the lower vertebra is backwards, the upper one is going forward, the lamina are in their place. And in prone, again, the femoral nerve stretch sign should be checked because a higher lesion as we know that the femoral nerve is L2, L3, L4 roots are make up the femoral nerve. So, and it crosses anteriorly in the thigh. So you have to lift the leg when the patient is prone from his knee, so as to ascertain the femoral stretch time. So this is clinical examination. And now, as far as the causes are concerned, it's a very long list of backache. Backache has a very long list of causes. So I have tried to make this simple as far as these causes which I have enlisted will be crossing over in each age group, but more commonly what is seen below 20 is only backache is common. In today's era, sports-related injury is common. Posture-related pain, that means riding of two-wheeler and all, or sitting for a long time. Adolescent scoliosis is a very common cause in below 20 age groups. Then again, tumor and all the general causes. That is one more important cause in the age-wise distribution is transient hip synovitis. At a young age group, patient can have transient hip synovitis, which is self-limiting condition and can lead to backache. So if we diagnose lysis and listhesis on X-ray, it is another common cause. In the age group of 20 to 40 years,
civil surgeon.
viscogenic with only backache. So there is this degeneration has started, and patient will not have radicular pain, and he will have only backache. With this, he will have also radicularitis. Postural is again common, overuse of two-wheeler, because this is the active age group, earning age group, and in this age group you should think of as the history of overuse of two-wheelers. Now in this age group again, the spondyloarthropathies are very common, autoimmune spondyloarthropathy like ankylosing spondylitis, especially in male population. And again, avian femoral head. Now if we go ahead, 40 to 60 years, acute on chronic disc prolapse. Patient will present with acute backache with radicular pain. He has a history of episodes of backache in the past. Also, you may have only backache that will be due to chronic disc degeneration. Facet arthropathy that is again related. So now we are looking at a group where degeneration is more common. Ligamentum hypertrophy, change in center of gravity, flabby abdomen. So I just explained that how the change in center of gravity will cause backache. And then degenerative instability and other causes. About 60, osteoporosis is the main cause. Microfracture. So previously, when we used to look at patients above 60, there is body ache. So probably we used to label them as psychiatric problems and all those things. But with the advancement in knowledge of osteoporosis, there is no fracture on the X-ray, and still the patient is having wearing backache. Because at the microscopic level, the bone is breaking and healing, breaking and healing. So all this is related to osteoporosis. So bone mineral density as an investigation is very important in such cases. And in general causes, somatization, anemia, hyper. One very important cause which I have found interesting in my practice is one half of the body is paining. You must have also come across this complaint. एकच साइड दुखते डोक्यापासून पार नाकापर्यंत एकच साइड दुखते. So if you ask only one question, that do you have a fear of hemiparesis, they will say yes, because they must have seen some patient in their lifetime of paralysis and they try to impose themselves on that condition. So this is another important and very easily treatable cause. Coming to less common causes, infection, but tubercular spondylolisthesis is again on the rise with rise in the HIV patients and low immunity patients. Subacute pyogenic, swath abscess, fungal infections are other infective causes. Coming to investigations, nowadays MRI is very easily done and cheaply done as well. So usually there is a tendency to send directly the patient of backache to MRI. But X-ray stands its own value. I want to stress it here that MRI is done when the patient is lying down. You cannot do MRI when the patient is under stress. So all the stresses are happening when we are standing, sitting, and moving around. And at that time, backache is worse or the radicular pain is worse. So you cannot determine what is happening with the nerve root or the cord on the MRI. Actually, how the biomechanics is changing can be done only on standing X-ray with AP standing film, lateral standing film in flexion and extension. If you are not able to do standing films, at least ask for AP view, lateral inflection and extension. So that will immediately tell you about degenerative instability or congenital instability. So that is the importance of X-ray. DEXA scan for bone mineral density. That is important investigation, as I told you. Postmenopausal women, everyone should undergo this test because
परमार्कट आले का ते? हा हे बघा ना इकडे
50 to 70 are considered as active years of life now, retired, post-retirement age, and if some females sustain repetitive fractures at this age group, the medical fraternity is at the call. So we should be asking for bone mineral density more often than not, and that too on dual energy X-ray optometry. Not that ultrasound thing, because ultrasound has many fallacies. Patient of 20 years is also shown osteoporotic because calcaneus is tested. Calcaneus is as it is the osteoporotic bone. So you should ask for DEXA scan rather than anything else. Blood investigation to rule out autoimmune disorders and other general causes like anemia. Now, this is interesting. These are plain X-rays. If you see, this is the AP view. These are normal X-rays. And the left side X-ray is the normal one. How to pick up degeneration? Just if you see this level, okay, sclerotic, the discrete space is reduced, whereas this is not.
खबर नाही पण तर फोन करू पडशी येऊ नको चुकीचा माय आव्हान सगळं कॅरे निघतो
This round thing, got that round?
आहे ना इथे रूम आहे ना ये ना
Okay, on the either side.
तिकडे नाहीये काही
What does this tell you?
हो ते जास्त वाढलं म्हणजे आम्हाला मला बी लक्षात नाही या 3 दिवसात
Passage joint is formed by the lower articular process from the upper vertebra and upper articular process from the lower vertebra.
वरती तिथं
Now the next slide.
तिकडे गेलं नसतं ना त्या पाण्याने वाट काढली आता
Pathology on.
अरे काय सांगायचं आता
Now see what is happening.
बघा ना आता किती वाढले ते बघा ना ते किती गळतंय ते बघा तुम्ही
This is the passage.
हो हे काय ह्या इथनं आणि या 3 दिवसातच झालं बरं का 3-4 दिवसातच झालं
Simple plain X-ray.
आता इथं ते बी कशामुळे झालं समजलं माहितीये का इथे एक फोटो होते दोन तर ते फोटो एक तुटला म्हणून ते वरती चढलो आणि काढायला गेलो तेव्हा समजलं ते की इथं पाणी हे बघा दिसतंय ना ते त्यांना दाखवले फोटो बिटो पाठवले त्यांना फोन बी केला मी त्यांना सांगितलं एकदा बघून घ्या त्यांना फोटो बी पाठवले हो ना आता कुठं लिकेज आहे काय आता आपण काय सांगणार हो आणि कशामुळे झालं काय झालं हो असं थोडं लगेच कमी झालं असतं ना मग प्रॉब्लेम हो हे कालचं मेसेज खिडकीजवळ पाण्याची धार त्यांना मी ते दाखवलं असतं वरनं फोटो काढून हे कालचं पाठवलं मी तुम्ही बोला मग हे कुठं येते हा म्हणजे ते आहेच ना तुम्ही जे सांगायचं ते सांगा त्यांना मी त्यांना फोन लावतो त्यांना सांगतो की तुम्ही आलेले तिथे वरती एकदा बघून घेता का मग आपण फोन लावू हा चला चला मी आलो मी जरा शर्ट घालून येतो हा हो बरं भयंकर अवघड हो
So you are looking. So this is the right side and this is the left side by default. So you are looking at.
जरा एक मिनिट
Imagine like this.
थांब
So this is the disc level, the dark one.
आणि
And the gray, that is the bone. You can see the bone here. So on T2 weighted, the disc will appear as dark, and the nerve roots or the water will appear as white. So this is the nerve root, very heavily seen, and this is the root cutout. So if you have patient who has backache with radicular pain, and if you find this picture, probability is to be referred to a spine surgeon, right? So treatment, I would just highlight one point because the time is short. Rest has no substitute in backache. Rest, spend 5 minutes or spend 2 minutes at least to highlight the importance. The main function of spine is to transmit weight. And if you are giving analgesics, steroid drugs and muscle relaxant and in today's era, pre-gathering and all those things, and not asking him to take rest, it is not done. So at least 10 days of strict bed rest. Means 23.5 out of 24 hours he should be lying down, and it will not matter whether he lies supine, prone, or lateral, but he has to lie down. He has to get up only for his own daily course. So non-surgical intervention with wood block, facet block, epidural anesthesia, vertebral plastic for bone cementing. Surgical, commonest surgical procedure is disc excision, because prolapsed intervertebral disc is the most common cause of backache with radicular pain. And this is just to complete the talk. This is called as translumbar interforaminal interbody fusion, transpedicular interbody fusion. So what I have done here is pedicular screws are put. This is the pedicle, right? So this is seen on the AP view. It looks as if it is going in the canal, but no, it is converging, and these are the edges which fuse this level. So whenever you see instability with this problem and canal stenosis, you have to do a wide decompression. Now here no lamina is seen, it's totally hollow. Now, if you have removed such an amount of bone, it requires stability as well. Therefore, these screws and these cages are in place. I hope I have told something which can bring importance in your practice, and you can apply it in your daily practice. Thank you very much.
Thank you so much. I request our organizing chairman, Dr. Praveen Garg sir, to please felicitate Dr. Willis.
आप जब भी होते हैं
The quiz has been given on your WhatsApp group. Please go through this. You can solve the quiz.
ऑनलाइन नहीं है मेरे पास.
Now we move on to our next topic, chest pain. How to approach a patient with a chest pain. To guide us on this topic, we have with us famous cardiologist Dr. Hasmukh Gurjar. Dr. Hasmukh Gurjar sir is a renowned cardiologist in Pune. He has 21 years experience in this field. He has been associated with various prestigious hospitals, and some of his services provided by him is patent ductus arteriosus vascular surgery, coronary artery bypass grafting, and mitral or heart valve replacement surgeries. Over to you, sir.
सगळ्यांना चहा त्याची तलब लागली माहिती मला, आणि खूप सॅच्युरेशन झालं सगळं. 3 लेक्चर झाले ऑलरेडी. ते पीपीटी पाठवलं लागली ना, त्याचे व्हिडिओ रन होत नाही, त्यामुळे मला बॅकअप पेन ड्राईव्ह ठेवायला लागतो. बेसिकली हे लेक्चर माझा बऱ्याच लोकांनी ऐकले पण असेल. ज्यांनी ऐकलं त्यांच्यासाठी रिव्हिजन आहे, ज्यांनी नाही ऐकलं त्यांच्यासाठी चांगलं. हे चेस्ट पेन का डिस्कस करतो सगळ्या कॉन्फरन्स मध्ये, सगळ्या सीन मध्ये, कारण चेस्ट पेन एक असं काउज आहे ज्यांनी पेशंट वाचू पण शकतो आणि थोडंसं नेग्लेक्ट झालं की पेशंट दगावू पण शकतो. त्यामुळे बेसिक डिस्कस करणं वारंवार महत्वाचं आहे. मला दिसत नाही वेळ दिलेला आहे. वेळ एक्सटेंड करायला लागली हात वरती करा, म्हणजे लेक्चर बंद होतो. मी भारत हॉस्पिटलला अटॅच आहे, तिचं नाव असेल तरी.
ये वो भारतीय विद्यापीठ के ऑडिटोरियम में जाना है।
बेसिकली चेस्ट पेन म्हणजे
ठीक आहे.
काय की तुम्हाला कार्डियक असून जाईल नॉन कार्डियक असून जाईल चेस्ट पेन इज व्हेरी इम्पॉर्टंट बिकॉज जर नॉन कार्डियक असेल तर ठीक आहे पेशंटला काही त्रास होणार नाही किंवा आपण वाचू आपल्याला काय मेजर कॉम्प्लिकेशन होणार नाही पेशंटला पण जर आपल्या ओपीडी एखादा चेस्ट पेनचा पेशंट आला ओपीडी पेशंट आपण बिझी 15-20 पेशंट पुढे थांबलेले आहे चेस्ट पेनचा पेशंट आला तर त्याला कसं अप्रोच करायचं खूप महत्वाचं आहे लेक्चर व्यवस्थित आहे कारण लेक्चर नंतर क्विज पण आहे त्याच्या पुढे आणि क्विज नंतर गिफ्ट पण देण्यात येते त्यामुळे बेसिकली आपल्या क्लिनिक मध्ये एखादा पेशंट आला चेस्ट पेनचा तर त्याला कसं अप्रोच करायचं ठीक आहे चेस्ट पेन तुमचा ऍक्यूट चेस्ट पेन आहे क्रोनिक चेस्ट पेन आहे का ऍक्यूट आणि क्रोनिक चेस्ट पेन आहे हे बघ डिफरन्शिएट करा ऍक्यूट चेस्ट पेन पेशंट एकच जरा छातीत दुखतंय छातीत खूप भरून आली एकदम चांगला वाटत होतं सकाळी जिम केली आणि एकदम छातीत दुखायला लागलं इट इज ऍक्यूट चेस्ट पेन यू हॅव टू डील व्हेरी अर्जंटली क्रोनिक चेस्ट पेन म्हणजे हा 15 दिवस झाले दुखते छाती थोडं थोडं दुखतंय अजून मधून दुखतंय वेळ मिळाला मग आता तुमच्याकडे क्रोनिक चेस्ट पेन समटाइम्स द पेशंट हॅज ऍक्यूट अँड क्रोनिक चेस्ट पेन म्हणजे दुखतंय 8-15 दिवस झाले आणि सकाळी एकदम जड उचलला व्यायाम केला किंवा काय स्ट्रेस झाला आणि एकदम खूप छातीत दुखायला लागलं बेसिकली हे डिफरन्शिएट का महत्वाचं आहे पण ऍक्यूट चेस्ट पेन हॅज टू बी डेल अर्जंटली काहीतरी सिरियस आहे आणि यू हॅव टू थिंक अँड डेल अर्जंटली क्रोनिक चेस्ट पेन असेल तर ठीक आहे तुमचा काही वेळ आहे तुम्ही स्टेप बाय स्टेप इन्व्हेस्टिगेट करा मेडिसिन चालू करा परत फॉलोअपला बोलवा देन यू प्रोसीड and also acute and chronic chest pain you have to deal urgently you can't just wait and think you have to deal urgently but ठीक आहे acute and chronic chest pain तुम्ही deal केलं बेसिकली 2 तास झाले दुखतं acute chest pain आहे आठवडा 15 दिवस झाले दुखतं chronic chest pain आहे नाउ इस्केमिक आहे इस्केमिक लाईक आहे ते नॉन इस्केमिक बेसिकली इस्केमिक चेस्ट पेन म्हणजे आपण पुढच्या स्लाइड्स मध्ये बघूया नॉन इस्केमिक चेस्ट पेन म्हणजे टिपिकल एकाच पॉइंटला दुखतं असं दाबलं की दुखतं चालताना दुखत नाही जिने चढताना दुखत नाही बाकीचं इतर वेळी कधीच दुखत नाही it is usually non-ischemic chest pain usually very common in females it is called as split syndrome म्हणजे costochondritis very common in females इथे आपलं टिपिकल पॅरास्टोनल लीजन मध्ये दाबलं की दुखतं आणि आजकाल बरेच नॉन कार्डियक चेस्ट पेन वाले जिम मध्ये जाऊन जिम चालू केले 4 दिवसात लगेच 15-20 किलो जोर मारायला चालू केले हे टिपिकल non-ischemic chest pain sometimes it's difficult to differentiate ischemic आहे का non-ischemic आहे बराच वेळ पेशंट म्हणतो की थोडं चाललं की धाप भरते किंवा चढलं की जिने चढलं की आपल्याला कळत नाही बेसिकली हे अॅनिमिया आहे का एकदम कार्डियकमुळे लागतोय का कशामुळे लागतोय तरी आपण पुढे बघू इस्केमिक चेस्ट पेन म्हणजे टिपिकल छाती भरून येते कारण पेशंट मध्ये I will try to speak in English and Hindi as well because there are many online participants as well. So basically, ischemic chest pain is typical patient having left-sided chest pain, heaviness in the chest, आणि बेसिकली एक्झर्शन केले की दुखतं पेशंटला कधी विचारा आता आम्ही पहिला प्रश्न विचारतो आता दुखतंय तुम्हाला चाललं की दुखतं का यू गेट पेन व्हाईल वॉकिंग यू गेट पेन व्हाईल एक्झर्शन आय yesterday only she had pain in left elbow while walking we treated her medically at days and she landed with inferior MI so it was cardiac chest pain any pain with exertion jaw pain with exertion backache with exertion shoulder pain with exertion any pain with exertion should be cardiac unless prove otherwise very important now the second group is ischemic if we do angiography in these first 3 conditions aortic stenosis severe hypertension and hypertrophic cardiomyopathy cardiomyopathy the angiography in these 3 conditions will be normal and again in severe anemia angiography will be normal so basically first 3 pathology madhe because of aortic stenosis hypertension HOCM there is LV hypertrophy and LV hypertrophy causes supply demand mismatch and patient get breathless so ह्या तिन्ही कंडिशन मध्ये angiography normal आणि anemia मध्ये severe anemia मध्ये per se angiography will come normal because of there is decrease in hemoglobin in the dyspnea which causes decrease in hemoglobin which causes breathlessness so before referring patient to a physician or to a cardiologist first get all the basic investigation done many times we see directly patient for angiography after angiography comes normal and then we see the report patient has got CKD patient has got anemia one patient came with severe breathlessness he was taken on table then we find it was something fishy it was an acidotic breathing and his creat was 6.7. So we cancelled his antibody. So before sending patient for any further investigation, get the basic investigation done, get ECG, glucocorticoid, all routine lab, hemoglobin, urea, creat, electrolytes, everything, and then only send patient for further evaluation. There are many causes of chest pain, not in details of this. Aortic dissection is very important cause. Even suddenly patient usually middle age to old age patient are severe एकदम छातीत दुखायला लागलं upper chest किंवा पाठीत जोरात बुक्का मारल्यासारखं दुखायला लागलं आपण कोणतरी जोरात धक्का मारला somebody come on back and patient suddenly collapses and then gets up after 2 minutes, 3 minutes and start walking. So it can be patient of aortic dissection म्हणजे excruciating pain झालं तर कधीच दुखले नव्हते छातीत पाठीत कधीच दुखले नव्हते it can be aortic dissection then think of because many patients pulmonary embolism GI causes one important one. Basically, esophageal spasm can cause something like angina. If we give sorbital to these patients, if pain decreases within 8 minutes, 2 to 3 minutes, it is angina, cardiac cause. If the pain decreases in 10 minutes, 15 minutes, it can be a esophageal spasm. It has to be very. History खूप महत्त्वाची cardiac मध्ये. Osteochondritis, cardiac neurosis खूप common आहे. आमच्या ऑफिसमध्ये एखादा अटॅक आला तर कोलॅप्स झाला तर मला छातीत दुखतंय म्हणजे खूप लोक येतात रस्त्यावर बघितले कोलॅप्स झालाय मला पण दुखायला लागलं इट इज कार्डियक न्यूरोसिस यू हॅव टू assure them we have to get the basic investigation you get ECG to go to the doctor and stress test and assure them that you don't have anything again the patient which comes with chest pain or OPD on office basis of the total chest pain about 11% has got polycystic angina 5% has got obstructive angina, non-ischemic mind, 5% has got mitral infarction. So this is 21 to 25% of patients has cardiac chest pain. तुमच्या ओपीडीत 4 पैकी 1 पेशंट येणार आहे डेफिनेटली कार्डियक असले त्यामुळे in all patient has cardiac illness to otherwise. We have seen many incidences patient comes to hospital casualty ECG is normal he sent back an analgesic and after going out of the hospital he collapses. There have got many incidences and that should not be missed. Again, what history we should ask? History of smoking, family history. Cannot get details of all this. Ability to get hypertension, hypertension, diabetes, smoking, age, passes. सगळे विचारतो आपण परत थोडं पेशंट म्हणतो I don't have anything and how did I get cardiac? Genetic factors also important. If both parents, father and mother are having diabetes or hypertension, the chances of having diabetes in patient or siblings is about 40%, 40 to 50%. खूप फॅमिलीज बघितलं आम्ही की सगळ्यांना डायबिटीज सगळ्यांना हायपरटेन्शन सो दॅट शुड बी टेकन केअर दिस इज वर्ड बाय ऑफ आवर ओन डिपार्टमेंट कार्डियक डिपार्टमेंट सेंट्रल ओबेसिटी आहे त्याला हायपरटेन्शन आहे डायबिटीस आहे हायपरलिपिडेमिया एथेरोस्क्लेरोसिस आहे त्याला मेटाबॉलिक सिन असं म्हणतात म्हणजे क्षार ते असं नसावं माणसाने दिस इज मेटाबॉलिक क्षार आमच्या डिपार्टमेंटचा वर्ड बॉय आहे अगेन विल गो टू डिटेल्स ऑफ दिस नंतरची स्लाइड इज व्हेरी सेल्फ एक्सप्लेनेटरी this red area which has been shown, if patient gets pain in any of this area, central chest or left side of chest or right side of chest, epigastric basically, epigastric area, both shoulder joints, inner side of the arm, radiating to neck and to jaw. If you get pain in any of this area, it can be cardiac chest pain. If you get a patient when she used to walk, 10-15 she used to get jaw pain. She went dentist 3-4 times, but nothing was in. Then she had an RCA lesion. So any symptoms after exertion, चाललं की पोटात दुखतं, चाललं की right arm pain, right shoulder pain होतं, left shoulder pain होतं, jaw pain होतं. Anything you have got, it has to be cardiac chest pain. Uncomfortable posture, छाती एकदम भरून आली, fullness of the chest, squeezing pain, एकदम दुखायला लागलं, एकदम सिव्हिअर दुखायला लागलं. या पेशंट OPD
infection पेट का हो जाता है
ECG was normal but it was cardiac.
ये infection होता है टाइफाइड हो सकता है गैस्ट्रो का हो सकता है
just comfort and light it थोड़ा सा गड़बड़ में
तभी समय पानी से फैलते हैं
anxiety nervousness severe sweating दर्द घाम आला ह्याच्या असं कधीच घाम नव्हता it can be a symptom of dyspepsia or migraine infection. First aid arrange for transport कोणतं लगेच फोन करा तुमची गाडी आहे पेशंटला गाडीत टाका हॉस्पिटलला घेऊन जा फिरत बसू नका ॲश्युरन्स ॲम्ब्युलन्सचा औषध जे काय मिळेल ते ॲस्प्रिन डिस्प्रिन 325 मिलीग्राम जर त्याला तोंडात चावायला दिली डिस्प्रिन 325 मिलीग्राम टू द चिव इट कॅन अबॉर्ट अन मायग्रेन इन्फेक्शन It's very important. Sometimes you have to be very cautious with blood pressure. Good only you can use clothes. 45 degrees angle with the patient of temperature. Call for doctor or ambulance. Do not wait for the doctor to come to home. Do not wait for the assistant. Rhythmic cough is very important. आजकल CPR awareness are there. We have seen a video which is viral for CPR, self CPR. Just call it rhythmic cough. जो तुरंत खोपड़ा काढायचा आहे, that avoid migraine infarction, and definitely CPR is an important thing. Not the details again. What medicines to take? Emergency drugs, disprin 325 milligram to be cheap or to be taken dissolved in water. Small glass of water and taking it. Lopidogrel 4 milligram start. Atorvastatin 80 milligram or 40 milligram. Solvitate 5 milligram. You should be avoided. If the pressure is very good and you can give the patient continuity, then only give solvitate. Or if patient is taken for primary angioplasty, you can give prasugrel. Or now ticagrelor is available and is used most commonly after aspirin. This last drug you can give in almost all conditions. You can give in migraine infarction, 2 tablets per day, 90 milligrams. You can give in migraine infarction. You can give in unstable angina, non-estimation MI, estimation MI. In all patients, you can give ticagrelor safely. So this basic medicine should be given in your OPD. Disprin, lopidogrel, statin, and ticagrelor. This whole medicine should be there in OPD. If it turns out to be non-cardiac, it will not harm the patient. A single dose of disprin or lopidogrel or ticagrelor will not harm the patient, but definitely will save the patient. So, in the again, what are the presentations of CAD? There can be no symptoms, especially in case of diabetes. What you have seen, diabetes get a silent MI. When they come to the in severe heart failure, they have got ejection fraction of 25%, 30%, 35%. Angina, each patients come to us, heart attack and sudden cardiac death are more common in younger now. आपण बघतो आता रोज वाचतो आपण व्हॉट्सअपवर पेपरमध्ये many girls are getting cardiac arrest because of over stress, over gymming, and overwork. All this leads to cardiac death. Basically, in younger age, the coronaries are normal because of any stress, maybe physical, emotional stress. There is rupture in the endothelium, formation of a clot, and patient get a heart attack, VT, and collapses. Older age मध्ये हळूहळू blockages तयार होत असतात. There are blockages slowly. So usually older patient will not get a sudden cardiac death. Older age because their heart is not prepared to take the ischemia. They get sudden cardiac deaths are common in younger, not older. For migraine infarction, you should have high index of clinical suspicion. प्रत्येक पेशंट येणारा चेस्ट पेनचा तुम्ही MI आहे असं ट्रीट करा त्याला. Every patient will come to your OPD treat as migraine infarction and it prove otherwise. Many doctors have seen patient recently. Doctor patient have got migraine infarction. Overdiagnosis, underdiagnosis going to be there in every hospital, every clinic. Sometimes over treatment is better than under treatment. Consideration. Atypical presentation, epigastric pain, right shoulder pain. There are some patients going to orthopedic because of shoulder pain, not relieved by medication, and you do the ECG, you get an inflammation. You do P, you get an MI. Atypical presentation you have to think of. कशानेच बरं होत नाही. दात दुखताय, डेंटिस्ट कडे पण बरं होत नाही, ECG काढा, कार्डियाक इव्हॅल्युएशन करा, you get a diagnosis. Definitely. Now, what is our role as a family physician? मी काय काय लक्षात ठेवणार? पेडियाट्रिकचा डोस करताना ठेवणार, पोलिओ म्हणजे वॅक्सिनेशन पण तुमच्याकडेच आहे, सगळं व्हायरल फ्लू पण तुम्ही बघता, डायबिटीस आहे, हायपरटेन्शन आहे, पेशंट पण सांभाळायचं पुढे पाठवून. तुमचा रोल काय आहे? डायग्नोसिस, ट्रान्सपोर्ट अँड ट्रीटमेंट. Now we have got WhatsApp and everything facilities. We can just take ECG and send to us. ECG machine सगळ्यांकडे असणं गरजेचं आहे. We see many patients have got asymptomatic disease. The ECG is after 24 hours, 48 hours, 72 hours, and they get an MI. So don't hesitate to call us anytime in the middle of the night. You can do ECG and send us. ECG machine नसेल तर ECG machine घ्या किंवा सांगा कोणाला, because it's very important. You can save a patient. Transport. Once you have done the ECG, usually पेठेमध्ये ट्रान्सपोर्ट usually अवेलेबल होत नाही. बरेच पेठेचे डॉक्टर आहेत किंवा पेरिफेरीचे डॉक्टर आहेत. ECG काढा, ECG MI तुमच्या गाडीत टाका पेशंटला, येऊन या. बाकीची ओपीडी सोडा. 15 पेशंट थांबलेले आहेत, ठीक एवढे येतील ते. इमर्जन्सी पेशंट नाहीये, ते इमर्जन्सी पेशंट नाहीये म्हणून पोट दुखते म्हणून तापाला 4 दिवसाला त्रास होतोय. These are not emergency patients. You have to treat that patient at the important, that at the earliest. So that is important. Now, you just see What are the investigations? MI diagnose करणार, to diagnose myocardial infarction, we don't require any खूप हाय फाय कॅथ लॅब लागते किंवा खूप मोठं हॉस्पिटल लागतं असं नाहीये. तुमच्या ओपीडी बसून तुम्ही MI diagnose करू शकता. फक्त ECG, only ECG, electrocardiogram is required to diagnose the MI. The proper history and electrocardiogram. Electrocardiogram, ECG will not miss 95% of the myocardial infarction. Clinical history is very important. Sometimes 5% patient we can miss myocardial infarction. If first ECG is normal, patient clinically have got symptoms. So repeat ECG after 1 hour. Repeat ECG after 6 hours, 4 hours. You treat him, give him antiplatelet statin. If patient pain is not severe, first ECG is normal and is not willing to get admitted or under observation, ask him to wait for 1 hour, get a second ECG, get a third ECG, repeat ECG after next day, and then confirm whether it is cardiac or non-cardiac. एकाच ECG वरती पेशंटला सोडू नका. बराच वेळ क्लिनिकल हिस्ट्री वी हॅव गॉट टिपिकल अंजाना हिस्ट्री आहे, but ECG is normal. It changes of myocardial infarction can come as late as 12 hours. 12 hours. त्यामुळे at least all of the patient for at least 24 hours. Almost I have experienced the same. If a patient comes at night time and with a chest pain, admit him. ठीक है, patient ने कुछ admit करा कारण you can save the life because in the morning you can the patient can be bleeding. So it's very important. The another test which is required once ECG is normal and you are still not comfortable with the clinical symptoms and patient character, get a 2D color Doppler done. This is a patient of with a normal echocardiogram. This is left ventricle. 95% of the MRs of left are of left ventricle. Now this is the patient with. This is not pumping at all. This is the patient with diabetic cardiomyopathy. त्यामुळे आपला पेशंट ह्या कंडिशन मध्ये येता कामा नये, जी आपण काळजी घेतली पाहिजे. आणि बरेचसे पेशंट आजकाल ऐकतात, म्हणजे कार्डियाकच्या बाबतीत तरी ऐकतात ते लिसन टू अस, दे डू द इन्व्हेस्टिगेशन्स. आवर पेशंट शुड नॉट कम ॲट दिस वे, दॅट इज आवर रिस्पॉन्सिबिलिटी. Aortic dissection is very common to diagnose with a CT coronary angiography done. Definitely see aortic dissection. The true lumen, false lumen are not going to be done. Why we are discussing coronary disease? There is exposure of coronary disease in India strikes at a younger age. Its bread and number of females are also on rise. Basically, stroke. Stroke is the patient it makes the whole family disabled. Like that, if the patient with myocardial infarction collapses, so he dies, he gets VTBA and he collapses, the whole family gets disturbed. So it usually strikes at a younger age and a bread and the person so has to be taken care of. Now, few lines on investigation. Stress test is a common test. According to guidelines, usually upon diabetic patient बघतो वर्षानुवर्ष, we see diabetic patients, but when they come to us, they have got diabetes of 10 years, 15 years. None of them has got an ECG, 2D color Doppler or stress test. Many patients, before getting an MI, we can diagnose coronary disease with this basic investigations. ECG, 2D color Doppler, stress test. Whereas patient after COVID, almost 50% of patients with diabetes we have diagnosed to have coronary disease, and we have done maybe intervention with them and they are now fine. So, प्रत्येक diabetic patient, usually according to guidelines, after 35 years of age, in all diabetic patients, you should get their cardiac workup, ECG, color Doppler and stress test every yearly to prevent them from cardiac arrest or cardiac complications. Again, contraindication versus the severe chest pain, unstable angina, class 3, class 4, don't do stress test. Unstable angina, don't do stress test. Post-mortem angina, we have diagnosed myocardial infarction, patient is stable, don't do stress test. He can have infarct on straight milk, he can have VT, he can collapse. And inability to perform. Usually, old age patients are not able to perform, so there is no need of stress test in old age. With contraindication for stress test or indication for coronary angiography. Not doing details again. So, nowadays, we do almost all angiographies are done by radial route. The advantage is that there is no need to lie down for 6 hours. If you do femoral route, patient has to lie down for 6 hours. Usually, older age patient are backache as the joint pain and patient can go to washroom. So, radial route is the best one. Even if patient is on warfarin, we can do radial angiography. It takes hardly 10 minutes. It is very safe, and patient can be discharged in 2 hours. So, almost all angiographies in Pune, in Bharati hospital are done by radial route. It's very safe. This beautiful pictures are of CT coronary angiography. Many patients are not able to do normal coronary angiography or not willing for normal coronary angiography, and we are expecting a negative stress rate or negative but there's no coronary disease. Even in younger patients who have cardiac neurosis, in whom we have to confirm there are no blockages. In that patient, we can do CT angiography. Again, it's a safe thing. There no admission is required for CT coronary angiography. You can directly walk to CT department, CT coronary and get angiography done. Usually in younger age, in post CABG patients and post TNT patients, we can definitely do this test with a non-invasive test and with good results. When you CT angiography, when there is no probability of capital, माहिती की त्याला काही नाहीये, पण त्याला assure करायचं. डॉक्टर assure करते की तुला काही नाहीये. अशा वेळेस तुम्ही CT coronary LBBB, sometimes LBBB is stressed in inconclusive. So in that case, we can do CT angiography. Maybe hypertrophic or dilated or ischemic cardiomyopathy we can do. Not in ischemic, rarely in ischemic. If you are suspecting DCM, we can do CT angiography post intervention, post stenting. That is how the states are working. We can do CT and post ABG patients. We can do CT. But the drawback of CT is high calcium score. I told you in previous thing. We get many patients who have done CT coronary angiography who have no symptoms. Retrospectively, we do stress test. If the stress test comes negative, there is no need of conventional coronary angiography. Not good. प्रत्येक पेशंट angiography ला तर त्याला angioplasty का bypass लागता असं नाहीये. There is something called medical management also. This is a short clip of angioplasty. Most of them are seen directly in cath lab, so not going details. There is a plaque of 70 to 80%. A wire is passed, coronary wire is passed. This is balloon. With the help of balloon, we inflate. We just make the plaque, make a passage for the stent. We remove the balloon, and then if we don't put the stent, almost 50% of the artery will collapse. 50% of the block will reoccur again, and we then deploy the stent, open the stent at most maybe appropriate deployment of the stent, and then we remove the whole thing. अँट्रोवॉलिमाचं पेशंट आहे, थ्रॉम्बोसिस केले पेशंट स्टेबल आहे, पेशंटला चेस्ट पेन काही नाही. अँजिओग्राफी का करायची? कारण अँजिओग्राफी केल्यावर हा 90% ब्लॉक बाकी आहे. देयर इज स्टिल 90% ऑफ ब्लॉक रिमेनिंग. इफ वी लीव दिस, he can have a re-MI. He can throw BTV and he can collapse. So all patients have got myocardial infarction, maybe non-ischemic or ischemic MI. Angiography is mandatory within 24 hours to see this lesions, because if he miss this lesion, he can have a second MI and he can collapse. So that should be taken care of. Angioplasty care on this side. So basically, stent insertion, stent expansion, stent remains in the coronary artery. Stent तो काढता येत नाही, stent हलत नाही. बरं थोडं पेशंट एकाच खुशीवर ढकलून राहतो, हलत बाबा stent हलेल, तसं काय होत नाही. पेशंट ट्रायल करत नाही. त्यामुळे हे सगळं पेशंटला पोस्ट सांगण्याची खूप गरज असते. जे आम्ही पायाला बँडेज करतो, पेशंट 7-7 दिवस आंघोळ करत नाही, ते बँडेज कसं ठेवतात. त्यामुळे स्टेटिंग नंतर हे काउन्सिलिंग खूप गरजेचं आहे. बायपास is again very common thing. Lima and Rima, both the arteries usually atherosclerosis doesn't come in these arteries. So they artery आपण ह्यासाठी वापरतो बायपास साठी. जेवढं आपल्याकडे टॉन्सिलचे ऑपरेशन होतं तेवढं बायपासचं ऑपरेशन होतं. त्यामुळे बायपासला घाबरू नका, पेशंटला घाबरू नका. न्यू हॉरायझन्स, हार्ट ट्रान्सप्लांट. हार्ट ट्रान्सप्लांट पण खूप कॉमन झाले आजकाल. आपल्याकडे भारतीमध्ये सुरू होईल होते लवकरच, पण उलटीमध्ये वगैरे हार्ट ट्रान्सप्लांट, शरीरामध्ये हार्ट ट्रान्सप्लांट चालू झालंय. युजली 40 to 60 च्या मध्ये जो ब्रेड येणारा पेशंट असतो, हे 15% 20% आहे. वय 30 आहे. तुम्ही काय केलं नाही तर तो 5 वर्षात जाणार आहे. पेशंट इज गोइंग टू डाय इन 5 years. सो इफ यू डू ट्रान्सप्लांट टू दॅट पेशंट, ही कॅन सर्वाइव्ह फॉर 40 years. ट्रान्सप्लांटचा खर्च 12 ते 15 लाख रुपये आहे. But it is worth considering in younger age. So that is very important. Gene therapy is still in process. Patients who are, आपण आजकाल सगळ्यांचं अँजिओप्लास्टी बायपास होऊन जाते, त्यामुळे ही वेळ येत नाही. पण ज्या पेशंट मध्ये we can't do angioplasty or bypass, in that patient we can do gene therapy. But gene therapy there is neoangiogenesis. नवीन ऍड्रेस फॉर्म होतात आणि पेशंटचा सिम्पटम्स किंवा अडचण कमी होतो. For primary prevention and secondary prevention, ideal goal of BMI, cholesterol should be under control, blood pressure should be normal. Ideal आपण हाईट पेशंटची घेतली, आपण वेट घेतो पेशंट मध्ये. हाईट इन सेंटीमीटर -100 should be his ideal weight. If height is 164 centimeter, -164 should be his ideal weight. Again, medical insurance is need. I will just come to last slide. सगळ्यांना माहिती आहे medication. This is the last slide. The person who comes to birth has a natural line of death. This is the natural line of death. If that person by any means get a double vessel disease or triple vessel disease, he can have a premature death. He can double vessel can have a triple vessel can have a premature death. In such patients, if we do angioplasty or bypass in these patients, again his line can come to normal in axial bypass. And his middle line, the yellow box indicates medical management. So bypass केलं तर बऱ्या ह्याच्यात ना तुम्हाला काय होणार नाही पुढचे 20 वर्ष असं नाहीये. You have to take medical management, you have to follow everything, and then only you can be normal. I think so. This was the last slide. Again, reversal of CAT is not made with degree of reversal is 5 to 10%. Rigorous commitment is required. Apply to only 5 to 10% of probability. Many patients say that मला 70% of angioplasty करणं गरजेचं आहे का? With medicine, whether the block will go. If you follow rigorous commitments, if you do yoga, meditation, exercise regularly, if you follow the diet, this reversal of plaque, the plaque from 70% can come to 60% or 50%, but that is difficult to see by eyeballing method. But definitely the plaque can be more stable. If there is 90% of the patient is having symptoms, we have to do intervention. But if there is blockages of less than 70%, that can be managed with medicine, and blockage can regress with medications and lifestyle modification. In conclusion, alarming increasing CAD, prevention and living moderation. अति गोष्ट कुठलीही करू नका. मला सुट्टी लागली महिन्याभर मी काय एक्सरसाइज नाही केली, एकदम पर्वती चढायला गेलो, 2-4 पर्वती चढली, असं चालणार नाही. You have to have exercise, appropriate type of intervention, reversing of the myth, and patient should be the target. Patientला जे काय बेस्ट आहे तेच करणं गरजेचं आहे. Thank you for listening patiently.
Thank you, sir, for this elaborate.
I have to give fast.
And I request our MCF President, Dr. Prakash Mahajan, sir, to please felicitate Dr. Hassan, sir. Now we will have a short tea break of 5 minutes. Our next lecture will be by Dr. Sanjay Galvani, sir. He is already here, so please make it fast. After 5 minutes of tea break, we request all our delegates to please be present in the auditorium. We will be sending the queries.
They cover the mouth, so you were here in an opposite nostril. Then she looked around and told me.
Hello. Hello. Hello.
Okay.